Hello and welcome to today's webinar, The Path Forward for FQHCs. This is actually the second webinar in our Path Forward series. The first was last summer, and times were a bit different. We were all in the middle of dealing with the challenges and fallout from a full year of COVID. So from the pandemic to social justice, the last 2+ years have been a roller coaster. Probably one that neither of our panelists or myself would have waited in line for, that's for sure. So 2+ years later, we've got the calluses and the scar tissue to prove it, but we've also learned lessons, and there's been stories of perseverance and really success stories. So in today's webinar, our panel of experts here will be discussing what we've learned over the last 2+ years, what worked, what didn't, what's changed for the better, and most importantly, what's next. My name is Tim Ketterman. I'm the VP of Operations for Adaptive Medical Partners. We are a medical staffing and recruiting firm located here in Dallas, Texas. We have a long history of working with and serving our FQHC and community health partners. I've personally been in this business for about 18 years, and I'm very excited to be hosting this awesome panel of guests that we have. So before we get started, I'd like to briefly introduce our panelists and give them each an opportunity to tell you a little bit about themselves, their experience. So Jennifer, you are our holdover, having participated in the first one. So I'll let you get started and introduce yourself first.
All right. Hello, good morning, good afternoon, everyone. My name is Jennifer McDaniel, or as my friends call me, Jen. I live in Omaha, Nebraska. My background is worked in federally qualified health centers for 16 years, 8 of those in a CEO capacity, and then transitioned to a consultant role. I currently am contracted also to work and complete site visits. So I do site visits and technical assistance, and also on faculty at NAC. So thank you, everyone.
Excellent. Thanks, Jennifer. It's really great to have you back and to see you again. So Sheri, I'll let you go next.
Good morning, good afternoon to everyone. I'm Sheri Reinhardt, President and CEO of the Pennsylvania Association of Community Health Centers. I have been privileged to serve in that role for 13 years. I actually started my professional life as an oncology nurse. My husband says the RN no longer stands for real nurse anymore, though, since it's been so long. But I spent 10 years in long-term care administration as director of nursing, and I spent 17 years as vice president of the Hospital and Health System Association of Pennsylvania, where I was able to work on policy and project across the healthcare continuum. And I think that's been a real advantage to my current role, because often it's the law of unintended consequences that you have to be most careful about. Thank you, Tim.
Absolutely. Thank you so much. We're thrilled to have you join us. And last but certainly not least, my fellow Texan, Michael, I'll let you back clean up here for us.
Well, good morning, good afternoon, everyone. It's such an honor to be on the screen with all of these individuals today. So as Tim mentioned, my name is Michael Glass. I'm the Deputy CEO and the CFO for a community health center in a little town, Greenville, Texas. It's in Northeast Texas. We see in 2020, we saw right around 30,000 patients. So my journey as to how I got in healthcare, I can really say I don't know, but I'm here. So I got a bachelor's degree in business and a master's degree, my MBA from Texas A&M University in Commerce. And I was actually in higher education for 5 years before I moved. Yeah, I was doing, it was a state entity. And then I moved to to healthcare after that. So glad to be a part of this today. Thank you.
Absolutely. Thank you so much. And thank you to all of you. So let's get started. So for those logging in, please feel free to interact, type your questions there at the bottom. My associate Jenna will be monitoring those questions and throwing them to our panelists or to me to share with our panelists. Our goal is to make this as informative and beneficial as possible to you, the audience. We've got a number of people logging in literally from coast to coast. So a lot of organizations with different perspectives in different regions of the country. And I think we have all learned that you feel and you're impacted differently based on where you're at. So our goal is to bring a group of panelists together that come from different perspectives. Jim from the consultative perspective there in the Midwest, Sheri is the president of the Healthcare Association, and then Michael, boots on the ground, right there, front lines, if you will. So, so based on our conversations with our panelists, as well as input from those that have already signed up, we've created some initial talking points that were the most prevalent that we have heard from our partners, community health centers, and those that have joined, and then my pre-calls with the three of the people on here on the panels. So my guess is we're going to get off script pretty quickly, but where it goes from there is going to be really up to our panel. So let's get started. And Jen, I am going to throw this first topic to you since you are our return guest. By far the most prevalent topic that we've heard is about workforce demands and staffing. From the great resignation to the emotional burden and burnout of our current staffs, what we're hearing from FQHCs and community health centers across the country is a real concern about workforce challenges. So Jen, starting with you, what strategies have you seen that are helping organizations combat this issue? Outside the box suggestions for struggling organizations? What are your thoughts on this topic to get us started?
Yeah, it's been very tough for health centers. First and foremost, thank you to all the health centers for your service, because I'm in the background. I'm not front line anymore, seeing patients or not doing any of that. So thank you so much for everything that you've done. Health centers have really, when you think about our workforce, we've really had to think outside the box. So as an example, with regards to the brick and mortar buildings, are we able to move from having everyone inside of the office, or are we able to help them work from home? So what does our technology look like? If you had billing, or if you have a call center, are you able to leverage technology to move that off to offsite? And then looking at, are we being more productive by, looking at individuals in their own environment? I think that's really important as well. The other thing I have seen is we are struggling, I'm sure as health centers are, to find support staff, not only providers, but if you think about it, registered nurses, LPNs, medical assistants. Sometimes we cannot compete with these sign-on bonuses that the hospitals are providing, or also we can't compete with the salary range. So are there other options that we can look at? Can we maybe help with childcare? Are we able to offer maybe, some gift card incentives or things like that? So where we may not be able to pay as much as we can, but can we take a look at our fringe benefits as well? The other area I'm also seeing is really looking at clinical support staff to work to the top of their licensure. And are we able to use clinical staff that we never thought that we could? So as an example, know of a health center in the Midwest that cannot find medical assistants. The hospital is paying $30 an hour to do COVID vaccine. It's ridiculous. So are we able to use paramedics or medics in a different capacity where they're not working 24/7, but looking at that set schedule for some work-life balance? So yes, we have to look at licensure, and each state is different, but can we utilize individuals in a different setting where they kind of understand, the clinical processes and workflows, and just utilize that a little bit different? If we have a staff that maybe we do on the job training, of course, maybe they're not due to state regulations, maybe they can't give vaccines, but are they able to room patients? Have we taught them how to appropriately do blood pressures, since the AMA guidelines have changed as well? So really looking at the actual workflow, and then you can use it as a PDSA for your QI program as well. So kind of looking at that workflow. And then finally, as you know, encompassing inequities, justice, as we know that there are a lot of most of the underserved or impoverished communities where, other things that are extrinsic affect them. So, not being able to pay for their rent, they may not be able to go to work, which, and goes to high blood pressure. So kind of looking at that overall structure. And that's really the essence of the community health center movement.
Sheri, you were going to mention something, I think.
Yeah, I think too, just being able to better communicate what the health center model is, it makes a big difference in recruitment and retention. I said in my 17 years with the hospital association, I never had to answer what's a hospital. And 50 plus years, we have way too many people who don't know what a community health center is or what makes us unique. And I think it's that uniqueness that when we're able to get people under our roof and to experience it where they can truly work as a team. I've heard from so many of our clinicians who, I'll give one example, National Health Service Corps success. She was going to do her time at a community health center and just fell in love with the model, and 30 years later, still at the community health center. Whereas if you're working in private practice, someone comes in, it's 5 minutes with the PCP and you know that they might have behavioral health issues, they haven't seen a dentist, and you have nothing more to do with that. But if you have a team that is looking at the person holistically, there is such job satisfaction in that. And I think we need to do a better job of recruiting as a community of community health centers. Get people interested in working in one of us. We can find you a small rural, we can find you a large rural, we can find you a large urban, we can find you a small urban. But we have to first get people to fall in love with the model. And then the other thing I would say that we have found to be really effective, and we were very lucky that we stood this up right before the pandemic, is a number of what we call peer network groups. So there's one COO at a health center and one CFO and one whatever, and it's lonely. And so we staff over a dozen peer network groups, give those individuals of one an opportunity to get together as collectively and to support one another, to learn and grow together. And based on the feedback we've had from our health center CEOs, it's really helped with both retention and growing their teams.
And those are great points. And I think the only other couple things that I may want to add, for our strategic planning process, staffing, retention, that's been on our strategic plan, probably like most other community health centers for many years. And we started on this before the pandemic began. But one thing, we actually made a shift with our HR department here at Caravaggio, and it used to be under the chief financial officer, and we shifted it to be directly under the CEO based upon the importance of what we felt the needs were for Caravaggio and our organization. And through that, we see the need now even more. We were looking at hiring and I wrote down the name of the job, a staff and provider engagement specialist, really focused effort on engaging both our staff and providers. So we're still working on hiring that position and really working through what that looks like. But at this point in time, however many months in since February of 2020, March 2020, we see the need even more now than ever for a retention specialist at our organization. We have about 180 staff members, and the organization's been in existence since 1977. So it's been around a long time, but this is definitely a need that we see right now. And then the other piece, and again, we started working on this a little bit before the pandemic as well. We're in a very large rural area, and recruiting is already difficult for us. We're over a 6-county radius or 6-county area. And we really started looking at, on the provider side and also on the leadership team side, work-life balance as well. That's what we're hearing a lot about. So we looked at, can we, not flex schedules, but can they work fewer than 40 hours per week? While we may not be as competitive in salary or competitive in other areas, but maybe we can compete on the number of hours they want to work. That does operationally make it a little bit more difficult in staffing, but we've just decided this is just something we're going to try. And I think COVID taught us too, and Jen, you talked about this. COVID taught us there's a way we can do business, and we can do a business from home at some points too. We don't always have to be in the office. So, that's another area that we're really looking into and working on, and not really getting caught up in the everyone has to be in this office, but there is other ways to do things.
Mm-hmm. I'd love to unpack the decision to put the recruiting under the CEO from the CFO. And I'm just curious because I'm sure this is a situation a lot of organizations across the country are facing. Strategically, what was the thought behind that shift that you felt you were going to gain a benefit for?
Honestly, kind of bringing HR matters and also the retention piece and also the recruitment piece more to the forefront of the leadership team, and really adding that person to leadership, to be honest with you. Because if you think about it, under the chief financial officer, they're dealing with all the finances, they're dealing with billing, they're dealing with, depending on the organization. When we did this, we actually asked and sent out on the listserv for everyone's organizational chart around the state of Texas. And when I say you've seen one community health center, you've only seen one. Everyone was so different as to how the structure was. But for us, we wanted that, we wanted the CFO duties to be able to focus on that, but actually then just bring the HR director and all of the pieces of HR to the table as a, basically as to how important it really is.
Okay. I'm curious what you think, and Sheri, this, as you have a lot of member institutions, do you think right now the workforce staffing issue is more a relation to the burnout and out migration of people on staff, or is it about still acquiring talent and bringing it in? It's probably a little mixture of both, but what we're seeing is that people are more concerned about what they're losing than even what they're able to bring in.
Yeah, it definitely is both. And that's why I think it's so important to focus on, what is the culture of your community health center that you're creating? Because if you have a leadership that everything that happens is kind of woe is me, rather than one that sees every challenge as an opportunity in disguise. And when people feel the most frustrated and when their behavioral health challenges increase is when they feel like little is in their control. And I always call up my grandmother on this one, but she always said, every time you're pointing the finger at someone, there are three of them pointing back at you. What can you do? And even when you don't have responsibility for something, you have responsibility. Some of my team give me grief that I'm always seeing the bright side of things, but the only thing that I truly have control over is my attitude. And I know that every day by the words I choose, I am writing my story. I am writing my organization's story. And so I choose to be positive because there is positive in every negative.
Absolutely.
So I appreciate you say that, Sheri, because it's, we talk about a culture of hospitality, right? And so, and I agree with Michael. Michael, I've been seeing a lot of models where it used to be where human resources were under the CFO, right? Or finance. We're now shifting HR to calling it people and talent, people and culture. It's more than just payroll, right? Benefits, doing the HR functions, but now we're looking at training, the emotional aspect. What do people want to do? We're looking at, and it's an investment in your organization. And so that's, you're right. And I do a lot of gap analysis for HR. And so really looking at that is kind of shifting it and making its own department, and it's an investment. So let's be honest, sometimes the HR department, let's say it's not a revenue generator, right? They're not providers seeing patients, but they're also helping to keep retention, because as you know, it's so costly to lose any staff, right? When we think about that. So
and people have to feel cared for before they can make other people feel cared about. It's important that we not only get our patients in, but that we can retain them as well. And I think people are so hungry after the 2 years of various isolation for people contact. We're all human beings. We need that. And to come into a health center where you feel welcome when you come through that door, you'll be back.
Yeah. Yeah. Well, we often say retention is the best recruiting strategy at times. So, so I want to shift our focus a little bit and stay along the workforce discussion. But that first question was a softball. So let's go into the real hot topic. And in our pre-webinar discussion, Sheri drew the short straw, so she's the one that gets this question first. But I think the most pressing issue we're seeing right now, and that we're hearing from 90% of the people who registered and participated, and even from our clients, specifically addressing the vaccine mandates from CMS. Sheri, when you and I spoke, you mentioned the great divide during your member conversations of what your member organizations are seeing, that battle that FQHC leaders are having between protecting public health while struggling with the vaccine versus freedom of choice debate, impacting staffs across all organizations, but really in healthcare with the CMS mandates. I'd love to hear your perspective on that from what you're hearing, and then have this discussion, because I think this is a real interesting topic and a challenge everybody's facing that's participating in this call.
Yeah, the good news is we're all facing it together.
Yeah.
But it is definitely challenging. We just did a query of all of our health centers, and we have 52 FQHCs and lookalikes with a presence in Pennsylvania, serving over 900,000 people. We have a vaccine mandate in Philadelphia. We have universities that have vaccine mandates in Pittsburgh, and a strong public health department. And most people from outside of Pennsylvania, when you think of Pennsylvania, think of Pittsburgh and Philadelphia. And we have a great T in the middle of those two, that we are predominantly rural. 52 of our 67 counties are predominantly rural. And that divide, you saw it in the election, and you just saw a recent study, probably the vaccination of red and blue. It is what our health centers, who take great pride in having bipartisan support for their entire history, are right in the middle of. Protect my patients, protect those who are uncomfortable working with individuals that are not vaccinated. And then I have another cohort that says, no way, at least initially. And I would say the good news again is our survey we did this week was saying, with the injunction on the CMS interim final rule, does your health center plan to continue moving forward with the mandate, or are you putting it on hold? And outside of Philadelphia and Pittsburgh, almost every health center is moving forward. But when you get into the rural areas, it's so much more difficult. And the health center leaders that have said, we believe we have to strongly take a stand on this. We're in healthcare. We have an obligation to protect when we know that there's a validated protection, have been, although initially really scared is probably not too strong a word, because of so many employees pushing back. Ultimately, most of those have had very few employees choose not to be vaccinated. There is no easy answer on it, and you've got to navigate in your own. You have to know your community. You have to know your organization. You have to step up and be a leader yourself. And you have to create the vision of, why would we say you must do this if it's not required across the country? And we have some really eloquent health center leaders who are creating that vision, and their employees are following.
Any thoughts, Jen or Michael, on that? And Michael, you are probably dealing with this daily.
We are, and we are in Northeast Texas, which is where we're located. It's a very conservative part of Texas. So just like some of the rural health centers in Pennsylvania, we're dealing with a lot of the same debates with regards to freedom of choice versus a mandate. And I went through our vaccination rates in some of our counties. So for our organization, we're about 70%. But for some of our counties, the vaccination rate's down in the 30% where we serve patients. We kind of took the stance whenever we were implementing it is we looked at those who were affected, which were the unvaccinated, and we actually made a PowerPoint presentation and we met with every one of those staff members. So there were 3 of us that did this, and we started this the week before Thanksgiving. And we didn't even schedule meetings. We just showed up and we started pulling different individuals. What we wanted our staff to understand is we wanted them to know the why. And we wanted them to have a safe space to where they could express their feelings and express their beliefs or whatever they wanted to express. And it was a no judgment area. You tell us, you just express what you want. And I have to say, we learned a lot from it. It was very sincere. There were honestly a lot of tears shed over it too. There are sincerely and deeply held beliefs on one side and the other. And our position is always just trying to make as many people happy as we can. But then also now we have a vaccine mandate. How do we do this? So that was the way that we thought it was best to move forward in having those conversations. And honestly, out of all the staff members, there may be still a couple that we do lose, but at the end of the day, we feel like we did everything we could to hear their side, hear their opinion, and just to let them know where we were coming from and to help them understand a little bit about the mandate, because there's so much confusion. If you look at social media, the news, OSHA's rule is on halt right now, and there's just so much confusion. They don't understand, and they think we're pushing something that has been halted or something like that. For our organization, I will say we did halt it with this temporary injunction currently, but it's not to say obviously that it's going to be permanent, and we'll kind of go from there after any other decisions are made. But for our organization, we did halt it for right now. We're still encouraging them, for those moving forward and wanting to get the vaccine, please move forward and don't wait. But for those who were kind of holding out, we did halt it for them.
I think Sheri and Michael, honestly, they were so eloquent, and I agree, it's actually education, right? It's fear of the unknown, right? And the misconception, not knowing, right? And these injunctions, holding certain things, that's hard on staff, right? And I appreciate, Michael, what you said, you created this culture of where you were open with staff to say, you didn't say, you must get this done. It was, tell me the reason, help me understand what your thoughts are. So it's really coming together. It's that education piece. I think it's important, though, for health centers to know that this also applies to board members. That's very important. And so I would strongly encourage health centers, their CEOs, to have that same discussion with the board. I think that's really important as well. Not something that's mandated. We know that whether it comes or not, from a public health perspective, to be open as well with your board of directors and have that discussion, but also education. Because even as healthcare professionals, when it came out in March, things have been changing almost weekly, right? And we all receive the emails from the White House, from NAC, from our primary care association, and that's difficult on us. So as long as we can also be able to pivot, but education is key as well. I will tell you that here in Omaha, our health systems, we have, 2 medical schools, they are strained. One hospital has lost half of their nursing staff. It's difficult. And so we've all said it's wherever you're at the end of the day, it's making sure that we're able to provide patient care, but also keeping our organizations, and our family, right? We're a health center family and a movement, being able to continue to do what we need to do.
Right. And it's a question about access to care too. I mean, these are the individuals that have been on the front line. They're comfortable managing the patients and dealing with the safety mechanisms and protocols in place. And it seems interesting that from a conversational standpoint, right now you wouldn't want to reduce the reduction of access and the health force. So it's a really difficult topic. As a point of clarity, Michael, I know there's somebody that wants to ask this question. When you did your meetings with your staff, one-on-one, was it your three on the one? Did you have the group? Or I'm just curious, as a point of operating, what worked the best for you? Because I guarantee somebody watching has that question.
Yeah, no, it was one-on-one. So there was 3 of us that went out to the different sites to do it, but it was a one-on-one meeting. We didn't want them to feel like, it was, there's a tendency in a culture, if there's 3 people on one side, one on the other, it just seems real uneven. We just tried to really make it pretty even and just an open conversation. And there were some that shared their feelings, some that didn't. And, we understood both ways, but that's just how we decided to do it at our organization.
Michael, can I ask a question? Who were the 3? What were the titles, right? So was it Human Resources, or who did you do?
Unfortunately, it was a week that Human Resources was out on vacation. So she was close by on the phone, but it was me and then our Director of Operations and actually our CEO. So it was the 3 of us that went out and did it. Excellent.
Well, let's shift a bit and put that heavy topic behind us, though I'm guessing it may come up again at some point. And let's talk about sort of the next thing that came up was sort of getting back to business. And it's a theme we've heard a lot, as this webinar is really focused on the path forward, which means eventually we all have to get back to business. I don't know if the conversation about the new normal needs to be had anymore. It is the normal. It's what we're dealing with. It is what it is. So Michael and Jen, you and I both sort of discussed this, and it's a topic we discussed, but Jen, I'm going to let you start. What does getting back to business mean for FQHCs and community health centers? And maybe more importantly, what should it mean? Has the definition changed when compared to pre-pandemic expectations? And what questions should maybe FQHC leaders be asking themselves to make sure that their facility and organizations are set up for not only success, but sustainability?
That's a lot to combat.
Yeah, I'm going to throw it all out there and get out of your way.
So, and as health centers, we did receive quite a bit of funding. So I will say we have the PPP funding, the provider relief. HRSA graciously, we were able to get some additional funding. So it really is also looking at, we were also forced, if you think about it, a couple of years ago, telehealth was this new concept to us, right? And now it's an everyday practice. So I would encourage health centers, when we're looking at new models of care or existing models of care, telehealth now is just this natural puzzle, right? It's a hybrid model. We're starting to see a lot more, I know we see a lot more in behavioral health, but now also looking at how can we add our patients into the mix of their clinical practice, so to speak, right? We always talk about how this is the patient. We want to, the patient, we want to revolve around the patient, but now we're able to, take our, diabetes, you can click like this and you get your A1C, so, you can check your heart rate now with your watch, there's all this new technology. So really looking at how we're able to leverage that technology. And while it's state specific, can we get paid for it? It's also being able to leverage this technology to be able to make it easier for our providers and clinical support staff, to manage some of these chronic illnesses. I was just working with a clinician last week. She was telling me about now patients can do their own blood work. Did you hear about this? Where is it? I don't know, but can I say the name or not? I don't know, Tim. It was called Everly.
We'll check it with our sponsors. So
okay. I guess it's something called Everly. It's not 23andMe, but Everly, where you can go in for $150. They can do their complete CBCs. They can do their thyroid. It is FDA approved. So we now have individuals, our patients that are able to access services that maybe we didn't think they could access before. So it's how to think about, now patient care has really transitioned. Patients can book their own appointment. You can use ZocDoc and go on and book your own appointment if your health center, uses that, or another form of our patient portal. So I just really think it's moving forward. We're into this technology phase, but we also have to remember those individuals that maybe do not have high health literacy. So we don't want to forget about them as well. So how do we make everybody happy, right? But that's kind of my thoughts.
Sheri, any thoughts there?
Yeah, a lot of them. trying to narrow it down. I think I could not be prouder of my health centers for how quickly they pivoted to telehealth. I think the challenge now, though, is the refinement. Telehealth is not appropriate for every visit. And it gets back to, I don't think you can truly do healthcare without the care. And that involves the people contact. So redefining and refining workflows, because we have the workflows of the past supporting a totally different way of delivering care. And we went from totally telehealth to now hybrid. And, how are we going to ensure that we're seeing people in person on a regular basis, as well as their telehealth visits? Because we didn't have to worry about that before. I think the fact that there was such quick acceptance, both in the provider community, policymaker, and patients to telehealth. And an example I'll give, we did for a year and a half and a weekly call, and now we're every other week with all of our health center leaders. And I was teasing one of our CEOs who never is on camera. And he said, well, my camera on my computer that I think I got from PAC, I gave to an employee whose computer camera went out. Well, let me tell you the story about that little camera from PAC. We had the state navigator grant because, or the CMS navigator grant, now we've transitioned to a state-based exchange. And we were asked how we were going to ensure quality of our enrollment assisters. This was many years ago. We've been a navigator grantee since the first year of the program. And we thought we had this wonderful creative idea. We were going to send webcams out to all of the health centers that had enrollment assisters. And we would schedule periodic appointments to join an enrollment assister for a quality check. We have wonderful relationships with our health centers. They freaked out. We were like Big Brother who was coming in. Look at where we are today. I mean, patients expected we are going from one telehealth meeting to another, but that's the other thing I think we need to refine. We used to have travel time, and that was think time. I know my days, it's not unusual to skate from one virtual meeting to another. We were completely virtual as an office for over a year, and I was working very, very, very long hours. And I thought, how can I make time for a commute now? And I will tell you, it's the best thing that I have to do, because twice a day, I have to totally disconnect. And I think that our employees that have gone virtual or partially virtual might forget some of the wonderful parts of having to go to the office. The organic conversations in the hall, the teaching opportunities. And so how do we create the new culture and the new work environment that optimizes the best of both?
Michael, any thoughts?
Yeah, the only, at Caravaggio, we've really tried to leverage, and Jen, you kind of talked about this, the funding that has come down. We've really looked at leveraging how we can use that funding to set us up for success in the future by expanding services, that kind of thing. So, but another thing that I kind of wanted to talk about is for our organization, I think all health centers nearly stalled and have been in this hamster wheel for so long, where all we're doing is putting out daily fires, anything related to COVID. And we've kind of made the choice and the decision of, okay, this is our new normal. So how are we going to survive in this new normal? So we're actually going back through the strategic planning process at our organization. So the last time we did it, we're kind of due for it anyways. But the last time we did it was in 2019, but we're actually starting it again in January because so much has really changed. And we need to be able to shift our priorities and our focus from the board level on down, is to how to get through and what we need to do, leveraging technology. Y'all mentioned that, value-based care. That's other things that we have to be prepared for, and we can't just stay in this hamster wheel because we're going to have COVID from here on out. So we just have to be able to exist with it pretty much at this point.
That's a really interesting point. Jenny, you and I talked and kind of a financial discussion with us back to business. And I know when you were consulting, you love the hard truths and being honest with folks. You had mentioned the conversation about how the PPE money is, are you sustainable without it? And like having that conversation with individuals, like it's almost giving the perception that, hey, we're okay. But if you really look back and look at the finances, maybe we need to take another look. I thought that was an interesting dialogue. I just thought we should touch on that.
Yeah, I've talked with a lot of CFOs, especially during, I also do site visits, and it's not part of the HRSA compliance or anything like that, but in my private work, and then, looking at this is, if you were to take that PPP money, and I'm hoping that all of the health centers were able to convert it, right, from a loan to a grant. But if you were to take that out, what would your organization look like? Are you able to be sustainable? Yes, we're a nonprofit, but that doesn't mean that you can't make money, right? A profit. What that means is your profit goes back into your company or organization in order to be able to sustain, to provide care, right? You're investing in your community. And so I've been seeing this trend where you have this influx of cash now, right? Your balance sheet, when you look at your balance sheet, you're in the black, you have your number of days cash on hand, but technically, if you didn't have that, where would you be? And so now that you have this, days cash on hand, or you have this influx, what are you doing with it? So are you able to invest it? We always talk about sustainability, with regards to health centers and their next step being generative thinking, right? So can you look at a foundation? Can you invest it? Can you invest it in your employees? Are you looking at building a building or expanding services? I will tell you, I've seen a lot of health centers that are now adding acupuncture and chiropractics to their scope of services, which is interesting, right? It's complementary medicine, but it's also, we're looking at the person as a whole. So really looking at it from a financial perspective of, if you didn't have this money, where would you be? And I think that's an interesting conversation to have. I'm happy the health centers got this money, but at the same time, we want to see if we didn't get it, what would our business look like?
Really good points, Jen. And the one other point I would make as you're assessing finances is, and I think, Michael, you said you're not an Medicaid expansion state, or you are?
We're not.
Because of the maintenance of benefits requirements on states, there are a lot of people on Medicaid right now that in normal times would be taken off the rolls, and at some point they will. And so keeping an eye on that, because for most health centers, that is, if not the best payer, certainly one of the best payers.
You're absolutely right on that, and that's one of our largest concerns when that does occur. Another thing that I kind of want to bring up, and this is something that it's interesting that the state association here in Texas is doing, is through some of the federal money that came down, they're actually kind of getting centers ready that want to participate for value-based care. And it's something that you can use the money, they went through attorneys or whatever, you can use the federal money, some of the federal money that you receive to actually help pay for this to get you ready for value-based care down the road. So that's something that we're working on. And then, Jen, you kind of talked about investing, and this
Yeah.
isn't your typical form of investing, but we are concerned. Year 3 of this grant, what happens? We watch this and we back out all that one-time money, and sometimes it's real eye-opening. Sometimes it's like, okay, phew. But what we've also decided to do is strategically, we're actually having an assessment completed by another company operationally and financially to really put some strategies together from the next 2 to 5 years, just to make sure our organization is running as smoothly as it can, and what other suggestions or what other things do we need to do. So we're really trying to, I would say, reinvest this in other ways as well.
Right.
Yeah, and our chief operating and finance officer has been working with a couple of our peer networking groups, the finance leaders and the billing leaders. And what they've asked for are key performance indicators for specific to FQHCs. And so we are working to be able to deliver that, so they have some comparative information that can support that analysis.
That's great input and advice and insight from all of you guys. Really appreciate you sharing. Michael, I want to, kind of along those lines of outside the box thinking that you and Caravaggio have had to consider. I want to throw this at you, as you're kind of on the front lines. You're there in the facility. So for all intents and purposes, I'd love to really get your input on what has worked for Caravaggio, what didn't work, and maybe what are some of the things that you did that maybe you would never have thought of doing, but actually turned out to be, wow, this actually is something that we're going to carry on, is going to help us into the future.
Yeah. So one of the things, obviously, that really worked well with us is telehealth. And I would say, on a more broader sense, leveraging technology as best we can. At times, being a nonprofit, we wear the nonprofit hat really well, and really don't think technology wise. And that's something that we've really worked hard to kind of counteract. Another thing, so obviously every community health center knows this, partnerships and relationships, they're so key. But I'm telling you, in the time of COVID, they were so key. Our local hospital at one point, they had so many patients that there was a tent set up outside. Their ICU was full. And it was a time whenever their staff were ready for boosters. And back in January, they were actually the provider that vaccinated most of the county employees and did drive-through events. But fast forward, now they have no staffing to be able to do that, not even vaccinate and give boosters to their own staff. So we were able to go over to the hospital and actually vaccinate all their staff so they could continue working and continue caring for patients in our community. Also, there was for shut-ins, you don't really think about those who may not be able to get out of the house to get a vaccination. So we actually, the county judge for one of our counties, we had a grant with them that actually took the vaccinations to particular communities and even to the house if we needed to be able to give the vaccination. I would say, I think the biggest piece that we learned and have learned from COVID already is the traditional way of work has changed completely from here on out. Be it work from home, less than 40 hours per week. You have to be very flexible, especially in a rural community where it's so hard to recruit staff to begin with. We've already mentioned, it's already been mentioned a couple times, the competitive salaries, traveling nurse salaries, sign-on bonuses. I mean, it is just difficult to compete. So, we still struggle today. Meeting before this, I was in a staffing meeting, and we still struggle, but hopefully we'll continue to find ways to help with that. And I think staffing and resources, to be honest with you, is the biggest hurdle we're going to have in the next 2 to 5 years, to be honest with you.
That's great stuff. Jen, Sheri, any thoughts outside the box thinking that you've seen successful?
Oh, it was funny, right before you said partnership, Michael, I wrote that a note to myself to bring that up. So truly, I mean, you hear this a lot in emergency preparedness. You don't want to be meeting people during the emergency, but it is so true all the time. You want the friend before you need them. And especially as we move toward whatever the other side of this is, I do believe there is enough money in the system, but we don't understand well enough what each other does and what each other's capabilities are. And if we were better at that, we could all stretch dollars and improve outcomes so much better. We at the PCA have had a strong history of strong relationship with state agencies, as well as a bunch of private partners. And it really helped during this entire crazy ride that we've all been on together. Our health centers, besides the quick pivot to telehealth, were some of the first to get tests. They were the first to get Moderna vaccine, and the only for almost a month. Some did contact tracing because there was no public health department in the area. We have worked hand in glove with our state public health department, and I think that the health centers were respected prior to the pandemic. They are both respected and admired for resilience, tenacity, outcomes, and so much more because of how they've responded. And the other quick thing I would say is Michael, when you were saying about home care, I'd like to see us take some of those lessons learned, because having served and serving on several national managed care boards and state, the issue of contention always is patient attribution, and health centers saying, we do a great job when your patients come to see us, and the managed care organization saying, but we want you to get these patients in, the ones that aren't seeing you. And we've shown we can meet people where they are. And I think we really need to build on that, because it's the sweet spot to make our MCO partners happier, and that we have more patients, and so we have better revenues.
HRSA allows that. So, please talk to your project officer. It's not going to be a Form 5B or a scope. You can't put someone's house in scope, right? But it can be a Form 5C, other activities. So, from just the HRSA blurb, the program requirements are this square, but you can fit a circle and a star in a square. So it's thinking outside this box is definitely. And I just want to add also self-care, I think, is important. I know that may sound kind of weird. I just say I'm just a consultant, but I feel like I've become close to a lot of my clients, and even doing site visits. I've seen senior leadership cry. I've seen the emotional toil it can take. So please take time. We now have Zoom fatigue, so thinking about that, I think self-care is really important. And I love, Sheri, when you said you have to, sometimes you have to turn this off. And that's important as well. So one health center I know brought food trucks in for their employees. I think that's really great. So thinking about self-care and being able to take care of each other. Where I live, like I said, I'm just a consultant, but I know that our PCA here in Nebraska has done a lot of amazing things, where I've even been able to contact them and say, hey, what can we do together? So I think, like we said, that partnership and collaboration is key. And also I've seen leveraging of resources between health centers. So can you share providers? I know that may sound kind of silly, but being able to share resources, I think is truly important.
And Jen, you stepped on my soapbox, which is no one is no one is just a anything.
Okay.
That the position would not exist if it was not important. So, and I mean, whether it's front desk or your garbage collector or what this, you know, the CFO, it doesn't matter. Nobody is just a anything.
I appreciate it because, you know, I'm on the outside, you know, and as well. And I will also say from a HRSA perspective, if you think about it, we've all gone virtual. And that also was a blessing because we realized as reviewers, we cannot come on site. It's too much. And so even that whole process has changed now, thanks to, you know, the feedback from everyone, the PCAs, from the health centers, to be able to have a better feedback. So I appreciate that, Sheri. I'm not just.
So we've got about 5 minutes left. So with that last 5 minutes, what I'd like to do is maybe kind of go around and let everyone give some final thoughts here, and kind of lead you down a path here, because there's some questions we've had come in and sort of a hodgepodge of things. But I think as we look forward and look ahead, I'd love to get your guys' perspective on what do you guys feel are the primary concerns as we look ahead into 2022, 2023. We've talked about value-based healthcare. You just mentioned attributed patients. Jen, you and I had an opportunity to talk about the fact that only 1 in 11 patients actually utilize or visit an FQHC, a stat that you shared, which in my mind would be something maybe we can expand upon that as FQHCs and get more education out there. And just the role in general of the FQHCs, has it changed? Fundamentally, are they different? They've been propped up as really, I think, the work that you guys have done has always been in obscurity. And I think it's been brought a little bit more to the forefront, but I think there's just a lot more that can happen. So I'd love to hear you guys' parting shots on sort of final thoughts as we look ahead and what some things that we need to be worried about on the horizon. Who wants to go first? I'll let you guys, dealer's choice there.
Sheri, you go, because you always have something inspiring to say.
There you go. All right.
I would just say, I think one of the things that truly is a positive coming out of this is we're in this together. And we were just lamenting, having a conversation about back in the old days when there were only a few channels on television. We all had that common, we knew that you watch the same thing, and we had a common language because of that. We've gone through this together, and when we look back, we will have a shared experience, a different but shared experience. We are writing our story, and I can't emphasize that enough. We can write a negative story, or we can write, you know, this helped us transform care. It gave us the freedom to do things that we would not have had in a normal world. And that's not minimizing the loss and the pain and the hardship, but finding meaning in going through this. And I think our health centers, those that are working optimally, and I believe the world is a bell curve. But the health centers that are on the leading edge of that bell curve have always looked beyond their walls to what difference can I make in lives and in this community. And I could go on, I could go down health center by health center, telling you some of the stories of transformation of individual lives and in their community. And I think that the pandemic has given our health centers more power to have that influence because we are more recognized and we have more tools.
Awesome. That's awesome. Michael or Jen, who wants to go next? Final thoughts.
You can go ahead, Jen.
Oh, I was just going to add, I think we're also looking at more, I hate calling them enabling service because they're wraparound services, but a lot of health centers, right, did a lot more for their community. I have seen food pantries, groceries. We know we have health centers in this world, in this country, that have actual grocery stores. And so I think we're transforming in the way we're providing care. It's not just like Sheri is saying, brick and mortar, but how are we able to expand that, but also looking at our staffing as well. So.
And I think, I always, in our organization, we always try and take it back to the patient too. And you know, one thing that I heard, and it's really meant a lot to me, and I think one of the biggest challenges we've had here at our organization is the amount of personal loss that everyone has experienced, along with all the professional hurdles everyone's having to jump through. That's just been one of the biggest challenges for our organization. And I was on a hospital call a few months ago, and one thing that they mentioned is, you know, we all look at a lot of data. All the time we're looking at data. But one thing that really hit home to me is when they said, you know, just remember this data represents people. So you're making decisions. These numbers you're looking at, it's an individual person you're making decisions about. And I think that's always something to remember looking forward.
Well, that's a great way to wrap it up, honestly. So I really appreciate all of you, Jen, Sheri, Michael. Thanks so much for your thoughts, your insight. You know, as somebody just commented, thank you all for your generosity in sharing your ideas. For those that are tuning in that didn't ask a question, that would like to ask a question, if you email it through the link or back to us here at Adaptive, we can get it out to Sheri or Jen or Michael if there's a direct question. We're really here to access and to help you guys. And we just really appreciate your contribution today. And thank you so much for all that you do. Everyone, please stay well, stay healthy, and have a wonderful, wonderful holiday season.